Okay, good evening everybody and welcome to this MOA Masterclass webinar. For further proceedings, I'll hand it to our convener, Dr. Abhijit Vayagawkar. Over to you, sir.
Thank you. Thank you very much, Ashok Sham sir. Good evening, everyone, and welcome to the last installment of the Master Series webinars in hand and wrist, courtesy the Maharashtra Orthopaedic Association. Like I mentioned earlier on, this was a brainchild of our president, Dr. Shinde sir, and we have had an excellent run so far, and we thought it would be apt to end these series with something more practical, and that is office orthopedics or office hand surgery. And today we again have a stellar presentation faculty as well as expert panel. We have Dr. Pankaj Jindal, who will be moderating the session, Dr. Anil Bhatia, he's a senior hand surgeon. We have Dr. Ashok Ghodke, Dr. Samrat Tauri, and Dr. Parag Lad will be joining in a little late. He's stuck up in an emergency. And then I'll be presenting a little bit on, if time permits and moderator permitting, to present something on practical procedures in hand surgery. The month of December is here. The year is about to end, and so is our session on hand webinars. It has been a wonderful run, and I hope you're all safe and sound at home. I invite Dr. Ajit Shinde sir to please address the meeting, and then we will proceed with the presentations. Thank you very much, sir.
Thank you, Abhijit. Good evening, dear friends. I, Dr. Ajit Shinde, President of Maharashtra Orthopaedic Association, welcome you all to our own MOA Masterclass webinar series. Today, we are on the way of reaching another milestone by successfully undertaking and now concluding various fruitful and elaborate sessions in the field of hand surgery. And today's topic is office and ambulatory procedures in hand surgery. For this Sunday evening, we have an expert in the field, Dr. Pankaj Jindal, who is moderating the session, accompanied by our own MOAEC member, Dr. Abhijit Vayagawkar, as a convener for this program. We are fortunate to have a group of eminent masters in this field as a panelist for this session, starting from none other than Dr. Pankaj Jindal, Dr. Anil Bhatia from Pune, along with Dr. Pankaj Ahire from Mumbai. Among case presenters, again Dr. Pankaj Jindal will lead the pack, to be followed later by Dr. Ashok Ghodke, Dr. Samrat Tauri, and Dr. Abhijit Vayagawkar. As we all know, a human evolved hand has played a crucial role in the evolution of mankind. Hand, though appears pretty smaller in size as compared to the rest of body, plays a vital role in our day-to-day function. This also has been proven by its wide cortical presentation in brain as well. However, with impaired or malfunctioning hands, subsequent significant disability develops, which is enough for a layman to become a physically, socially, and financially disabled for the rest of the life. And thus, our focus should not only be on detecting such dysfunctions and abnormalities in our daily outpatient setup at earliest, but also on treating them with effective daycare procedures, also nowadays called as office or ambulatory procedures, to provide an instant yet effective relief to the patients. Let's experience all this together now from the established ones in this field. So, without wasting any time, I request Dr. Abhijit and Pankaj to begin the session. Thank you very much. Jai Hind, Jai Maharashtra, Jai Amar.
Thank you very much, Shinde sir, for your succinct elaboration about the importance of the hand And I also welcome Dr. Pankaj Ahire, who has joined in. I just got a message from Dr. Patankar sir that he too will be joining in a short while. But without further ado, I would like to request Dr. Pankaj Jindal sir to please talk to us about hand splints, which is a very, very important aspect of outpatient management in hand surgery. Dr. Jindal sir, over to you, please. Thank you very much.
Good evening, everybody. Abhijit, am I visible?
Yes, sir. Yes, sir, you are, sir.
Okay.
Thank you.
We'll talk about splints in the practice of hand surgery. And if time permits, a second part will be about splinto surgery. It's a collaboration between surgeon, patient, and the therapist. The surgeon should know what he is doing, how he is doing. The patient should be compliant. Patient has the surgery and disappears is going to be a big problem in ending up with a very stiff hand. And therapist, what do we expect from the therapist? If the therapist thinks the hand therapy means wax bath and IFT, ultrasound, and matrix, then it's an absolute no-no. A therapist must be well conversant with not only static splints, but mostly dynamic splints and how to mobilize a joint. If they cannot do splinting and proper mobilization, probably therapists should not be a part of the treatment. The most important thing in not having a stiff hand is an absolutely no edema. I'll not talk about constricting suturing, but elevation is an extremely important part of the treatment. The moment tourniquet gets deflated, the hand is elevated, and hand remains elevated till the treatment is completed. And elevation to be effective has to be above the heart level all the time. A sling is an absolute no-no as far as I'm concerned, because sling gives a dependent position, and a dependent position is inviting edema, and edema means a stiff hand, and therefore no sling. Hand has to be across the shoulder on the opposite side, and the hand remains elevated. Of course, the shoulder has to be mobilized every now and then. Every 15 minutes, the patient takes the hand up in the air. Otherwise, the shoulder gets stiff. So hand elevation is extremely important part of the treatment to prevent edema.
Excuse me, Dr. Jindal, could you start your slideshow? You're still not in the slideshow.
I'm sorry.
Yeah. We could see what you had shared the screen, but it was not in slideshow.
Are you seeing the slide now?
Yes, the slideshow is better now. We could see the earlier slides also, but it was in the edit mode, not in the slideshow mode.
How about now?
Yeah, it's perfect now.
Okay, now. So elevation has to be effective, has to be above the heart level here. The next thing, if you have moved the patient back to the wards, see to it that the hand is not elevated with the sling. The moment you elevate with the sling, it becomes a constriction edge, and the distal part again gets swollen, and therefore it has to be uniformly across the whole length of the forearm and the hand here. Coming to the very basic splint, that is wrist immobilization, what we know as a cock-up splint. By cock-up usually means the wrist is an extension, but therefore I prefer to call it a wrist immobilizer, because rarely, at times, of course, you might have to immobilize the wrist in somewhat flexed position here also. Now, what sometimes we have seen, even if there's an injury to the finger, the patient tends to keep the wrist into a flexed position, and the patient gets a lot of pain. This is a non-functional position. The wrist is in flexion, MP joints are extended, and PIP joint are again flexed. And this unnecessarily gives pain to the patient because the wrist is flexed. A simple maneuver of keeping the wrist extended will get rid of the pain, and therefore very important to move the hand from a non-functional position to a functional position here. And here comes the first splint, a dorsal splint. Again, all the splinting that I am going to share with you are the ones that I learned from my teacher, Dr. B.B. Joshi, in 80s here. So this is a dorsal splint. It's made of aluminum. It's a malleable splint. You can mold the splint into various directions, and here the wrist has been extended to a 10 to 15 degree of extension here. It's reusable, and therefore it's highly economical here. As against this, now what I have mentioned here is a dorsal splint here. The wrist is in dorsiflexion here. As against if you, again the wrist is an extension, but the plaster is volarly applied. If the plaster is volarly applied, there's a tendency for the fingers not to flex because the MP joint gets restricted, and therefore it's preferable most of the times to use the plaster or the immobilizing device on the dorsal aspect and not on the volar aspect here. Again, whether you use it on the volar aspect or the dorsal aspect, see to it the MP joints, unless absolutely essential, are mobile. Here the plaster is in the volar aspect. Yes, the wrist is an extension, but it is going across the MP joint and preventing MP joint flexion. And therefore, see to it this restriction of the movement of the MP joint is not unnecessarily passed on, whereas the aim was to immobilize the wrist alone. Going to the next one is the first web splint. A lot of commercial devices are available. Again, the splint is a dynamic splint, which means the splint has its own inherent tension to generate a stretching of the first web space. It can be used, say, about a month later after the wound has healed, and you stretch out the first web space here. 2 months down the line, patient can be encouraged to flex and strengthen the muscles of the first web space also. But important thing is, only once the skin has healed, then only institute this splint, otherwise it can cut through. The gauge of the wire can be variable, and use the one to which the patient is comfortable and does not unnecessarily give pain. Again, see to it all the splints that you use does not give any pain to the patient here. There's another splint, again commercially available, and it is used for opening up the first web space, a dynamic splint. Here again, this wire is a spring wire, and it has its own inherent strength to open up the first web space. This bar which is present here keeps the first metacarpal from going into a radial abduction and keeps the thumb in palmar abduction. It avoids going into the plane of the fingers. So this is a bar which is preventing the thumb is going into the plane of the fingers. So first web space dynamic splint here. Coming to the metacarpophalangeal joints here, often the patient is not able to flex the fingers fully at the MP joint for whatever reasons here. And therefore, these are extremely useful splints for keeping the MP joint flexed. In the earlier webinars, those who attended, there was a point that how do you immobilize after fixing the fifth metacarpal? Now, you fix the fifth metacarpal nicely, but if you don't flex it immediately, subsequent days may become extremely difficult. And therefore, initially, you keep the plaster with MP joint flex. When the patient learns, and you can flex and extend it. So this is what the sling is doing. It is keeping the MP joint flexed. You can use multiple such slings on the various fingers to keep MP joint flexed. But what you're seeing with this 4 splints looped around the proximal phalanges to flex the MP joint, it is flexing the wrist also. The moment you flex the wrist, then you have problems. And therefore, it is important to prevent wrist flexing simultaneously with the MP joint, because this can become sometimes extremely painful here. To anchor these loops, you have a band on the volar aspect of the wrist here, made of various materials. It can be leather, it can be resin, it can be anything here. So you have a combination of MP slings and a band on the wrist to anchor the rubber bands here. But as I said, you can also get a flexion of the wrist with these, and therefore you have to prevent it by applying a splint on the dorsal aspect. So you will have a combination of these 3 things while you are flexing the MP joints here. Coming to the PIP joints here, these are again inherently elastic rubbers which are used for extension of the PIP joint. You have done whatever surgery, if you are not able to achieve a full extension of the finger, or the patient is not able to extend it by himself, then these are the assisting splints which are anchored with Velcro, and gradually over a period of couple of days, the patient is able to achieve full extension of the PIP joint because of the elasticity of the rubber here. You can use multiple rubber devices on fingers. Very important, you have to undo these Velcro fasteners every half an hour, because on the dorsal aspect, the patient gets sore here. And therefore, undo these splints every half an hour. Let the patient move the finger if allowed, and then reapply the splints. There are various alternatives which are available commercially. These are Kapner splints and joint jack splints here, and there are various other modalities which are available. But the bottom line is all these are available, and they are not static splints, they are all dynamic splints here. What about mallet splints? Again, these are work on the principle of 3-point fixation. A lot of them are commercially available. This is another commercial preparation which is available. And what you notice here is this is keeping the wrist in, the distal interphalangeal joint in neutral to hyperextension here. And it is just short of the proximal interphalangeal joint. Again, commercially available stack splints are available, made of elastic, made of silicon. I don't think the silicon. This is thermoplastic splint, which is available here. But important thing is once the patient wears it, see to it, it is of appropriate size here. And it does not give rise to a sore here. Because the moment patient says, I've got pain, just see what's happening. What is the cause of pain? And it is usually some kind of soreness, which is coming up because of the edge of the splint here. Whether to immobilize the PIP joint or not, it is not necessary. You don't have to immobilize the PIP joint. See to it the PIP joint is free, and therefore the splint is only across the distal interphalangeal joint. Buddy splint is common. I am not going to elaborate on that. Coming to the combination splints, again, these are commercially available here. What it is doing is keeping the wrist into an extended position, and is exercising the MP joint and the PIP joint here. What it also is doing is stretching the volar aspect if and when permitted, as and when permitted here. This on the ulnar side of the same hand here, wrist is in extended position and the splint is a 3-point fixation, again loaded with the spring. You can flex it against the resistance to strengthen, but when the patient is not using it, it is stretching the structures on the volar aspect here. Coming to the elbow joint, you have a turnbuckle splint, which can stretch out, say after you have done an arthrolysis of the elbow, and you have this kind of a splint available for stretching the elbow joint here. Coming to the trauma here, how much time do I have, Abhijit? 5 minutes, 6 minutes? You are muted, please.
Sorry, so you can go on, sir, no problem.
Okay, so all fractures don't require splinting as a treatment protocol here, nor do all patients require surgery. All fractures require surgery, scientifically speaking here. And therefore, treatment has to be individualized in all these patients here. The splints are indicated as a definitive methods of treatment for closed fractures, extraarticular fracture, and when they are stable. They may be required as a part of the treatment protocol as a follow-up after surgery to either immobilize or mobilize the joints here. Surgery would be indicated if it's open, it's an intra-articular displaced fracture, it's irreducible, it's reducible, but the fracture slips, and a polytraumatized hand here. There are various methods of treatment, whether bone graft is used to stabilize, K-wires, steel wires, combination of screws, plates, and external fixator, to which I am not elaborating. But what is important, you need a safe surgeon. Otherwise, any modality can give rise to a very stiff hand here. So there are iatrogenic complications with surgery, whether over distraction, unnecessary immobilization, wound not closing, and this kind of fixation. Let's talk about the examples of splinting here. This girl presented to us with this kind of treatment for a second opinion here. Before I could see the x-rays, she said, what can we do about this? So I opened up this dressing. There was a volar slab extending across the wrist, across the extended MP joint, across the digits, right up to the tip here. And once this volar slab was undone, we have another co-band, another stripping inside. So once we took out this slab, and this was another immobilization. So there's a buddy splint further here. And then we showed the x-ray. This is the injury she has here. So for this x-ray picture, the treatment was immobilization of the wrist, MP joint and IP joint, and everything is packed together. So this was about 2 weeks after the injury she had presented to us. We very gently, the word is very gently, stretched it, and this was not opening up. So this was a stable injury here. And probably the treatment was a centimeter wide buddy splint and mobilize the finger. If this continues for 3 weeks, 4 weeks, the stiffness becomes a nightmare. It takes months sometimes to get out of the stiffness. And therefore, unless absolutely essential, please do not immobilize a joint unnecessarily. This was another patient who presented with a volar splint here. And when we opened up the splint, this is what was happening. There was a scissoring. This is the kind of fracture which was displaced and rotated. And therefore, splinting cannot be equated to treatment. You have to see to it the finger are not scissoring, there is not overlapping, they are not shortening, there is no pseudo clawing. If these are the things, these are the patients who will require surgery here. So this was scissoring, and therefore a splint was converted to open surgery. So this is how the patient presented. We fix it. There may be options. People may prefer screws. I prefer to fix it with K wires here. On the patient, plaster. Now again, as I said, the most important thing is the wrist is in majority of situations, the wrist is in extension. MP joints are what we are noticing, the MP joint extended, IP joints are immobilized. And this is again a non-functional position, and this just guarantees stiffness. Unless absolutely essential, the wrist is in extension, MP joints are flexed, and IP joints are allowed to move. Majority of situations, that's a general principle I'm saying here. And this was yet another patient presented with a fracture on the volar lip here, and this was the immobilization. So unless important, immobilizing unnecessarily is inviting unnecessary stiffness. Sometimes patient just cannot get out of it here. So for this injury, we remove the plaster and early range of motion was instituted. So message here is avoid unnecessary immobilization, and just ask yourself what you can do to avoid immobilization and early mobilization here. Another patient with fracture the phalanx here, fracture the metacarpal here, treated with a plaster across the MP joint extended. What the plaster is doing? The plaster is causing further deviation of the finger here. And this is how the patient presented. Unstable deviated fracture needs surgery and correction. Applying plaster will give only a stiffness and an added deformity here. Another patient presented with a fracture of the phalanx here. Interesting injury here, and sorry, interesting for us, but for documentation purpose, fracture the proximal phalanx here, treated with K wire here, stabilized here. To this, a buddy splint was added. To that, for those who understand, a Kleiner traction unit was also added here. And now this was written on the documented on the paper. You will have a permanently stiff finger. The finger is not going to move. We analyzed the X-ray, and did we notice any involvement of the joint? The joint is not involved. It's an extra-articular injury, and there is no reason why it should be permanently stiff. And therefore, the first thing we did it, remove this thing, because combining several things which have nothing, there was no volar injury, there was no flexor tendon injury, and therefore putting this is only basically a one word to describe that is natak. This has no meaning. So this rubber band, this nail traction has to be removed. Since it has been fixed with a K wire, adding a buddy splint is also not justified here, and therefore we mobilize all the joints, we didn't do anything to the K wires which were put in earlier, and mobilize the joint and could get a good range of motion of this patient. So again, very important thing is, unless absolutely essential, do not add immobilization and add regimes which have no scientific basis of addition here. Again, splinting here. Now remember these ready-made splints, these are malleable but are too rigid here, and then can cause pain here where there are bent. And therefore see to it, one thing, unless absolutely essential, see to it they do not cause unnecessary pressure, or they can cause pressure sore and pain here. So this was the splinting, and this is the patient who had the injury to only the terminal phalanges here. Any involvement of the PIP joint or the DIP joint, there is no involvement of these joints here. And therefore, if at all, the splint should have been only on the distal interphalangeal joint, but PIP joint should have been free. Since it is extending to the volar MP joint crease, the patient will not be able to flex the MP joint either. And therefore, one splint cannot be universally applied to other situations. And therefore, watch out what splint you are using here. Other patient with a hairline fracture here. This was treated with a splint. The moment we remove the splint, what we notice again, the patient has scissoring, and therefore no fracture is a hairline fracture, requires no treatment, no surgery. If there's a scissoring, this has to be corrected, and this is what we did to get a good range of motion here. This patient again presented with a splinting. There's a suture line that you are seeing. He had a fracture of the proximal phalanx. This was treated with an external fixator, wire going to the MP joint, fracture getting distracted here. And obviously it ended up with a non-union here. Non-union was again plated, and now this plate was getting loose. Can you see the wire is the screw is going into the joint, and there's no hold on the proximal fracture fragment, and there was a discharging sinus to overcome this. So basically, this did nothing. This only caused stiffness to the hand, to the stiffness to not only to the finger, but stiffness to the finger hand as well. And therefore, use of the splinting has to be extremely judicious. Otherwise, you can defeat the very purpose for which the surgery is done, and very purpose for which the splinting is done here. And the last one I'll share with you. This patient had whatever injury I'll share with you here. A plaster has been given. The splinting is on the volar aspect. The MP joint is an extension. The edge of the plaster is too distal and prevents flexion of the MP joint here. And with the splint on the volar aspect, the patient is neither able, and it is tied up also. So he can neither extend it, he cannot flex it also, to which some traction has also been applied here. How do we justify this? Because the aim of treatment is to mobilize, otherwise the patient gets a stiffness here. And what was the injury? The patient had fractured the third and fourth metacarpal. When we remove these splints, what are we noticing? Is there any scissoring? There is no scissoring. Is there any collapse? There is no collapse. Is the shape of the finger length is maintained? It is maintained. And therefore, this much of immobilization had no scientific basis. Early mobilization was instituted, and the patient had a good range of motion. So in summary, treatment needs to be individualized. Splint alone sometimes works, sometimes it is harmful. Therefore, splint cannot be uniformly be the treatment for all fractures. Do a minimum intervention and maximum mobilization. Aim is stable fixation, and use common sense. Unnecessary immobilization can create more problems than good and lead to a very unhappy patient here. I thank you once again for patient listening. Any question for me or whatever? Abhijit?
So I think Dr. Patankar is already here.
Okay,
so we could ask him to take over and lead the discussion. Thank you, sir. Thank you for a wonderful presentation.
Thank you.
Yeah.
Hi, Hemant.
That was a nice presentation.
Welcome, sir.
Yeah, thank you. I would like to ask the panelists or the faculty to give their comments on this. Pankaj, I can see you here. Anil?
Hi.
Hi. Anil?
Yeah, hi.
Your take on this? Do you want to add or do you want to comment on this?
No, I agree with the points being raised about elevation above the level of the heart, maintaining standard functional position, supporting the interphalangeal joints in extension, keeping the MP joints flexed. These are standard practice in our all across the globe, and we must. There is absolutely no reason for us to change anything of that. We do observe overzealous application of techniques tangentially heard by some of our colleagues, and that inevitably leads to trouble. As Dr. Jindal has concluded, one has to be sensible. And if something that I had mentioned in the last session on fractures as well, if the fracture did not get displaced from the time the patient got injured and reached the clinician and the X-ray was taken, then it's not going to get displaced ever. So then to put immobilization across all sorts of joints that do not require immobilization is just subjecting the patient to torture. So that point has been highlighted very well by Dr. Jindal, and I think we should go with that.
Pankaj?
Yeah, good evening, everyone. One of the things which, of course, I learned using these fantastic splints, looking at Dr. Jindal, Dr. Patankar, Dr. Warrior, over last more than 2 decades. Before that, I had not much familiarity with the splints. One thing which I have learned and have tried to follow in my practice is to get familiarized with the splint myself first, what it does and what it does not do before I prescribe to the patient. Unless I have seen and handled the splint myself, it is never prescribed. To any splint, no matter how small, big, large, complicated, uncomplicated, is applied by me, by my own hands. My assistants don't do it. The therapists don't do it. The orthotists don't do it. So this way, we ensure that what needs to be immobilized gets immobilized in a correct position. And whatever are the liberties that the splint offers are adequately utilized by the patient. Once splinted, the patients are asked to follow up on a very regular basis. Most of the times they follow free of charge in the OPD just to show the hand that it is doing well, and they walk out of the consulting room. Sometimes it's just a 2-minute visit, but patients are encouraged to do it. And now with familiarity with video calls, sometimes I just ask them, I want to see how you are maintaining the splint at home. So continued observation of the splint is very important. These are the few things which I follow with these splints. Splint by themselves are not bad. Splint by themselves are not good. How we use them correctly is going to decide their utility.
Yeah, Abhijit.
I have a quick question, in fact, and I think the talk was very self-explanatory, but yet we see patients coming or presenting a little late with edema, stiffness. So how, and a lot of times, more often than not, they are prescribed these enzymes to reduce the edema and some kind of a splint that is kind of an ad hoc. What is the role of, we now have these thermoplastic splints that, progressively correct certain stiffness positions. Are there any splints or any protocol that would help or aid with edema management or compression stockings or sleeves that would help? So I would like to pick the brains of the entire expert panel on this, please. Thank you.
Okay. Yes. Can I start?
Yeah, please.
Yes. Edema, yes. So as far as enzymes, I don't prescribe. So trypsin, chymotrypsin, yes, I don't use them. I believe strongly in elevation. Edema, other devices, yes, I will encourage the patient, if at all it is edematous, to roll the hand from distal to proximally, keeping the hand elevated as often as is possible, maybe every 15 minutes, every 10 minutes for whatever number of seconds. So yes, that works. We can stitch up hand crepe bandage rolled up into finger stalls over each of the finger, so it gives compression. Finger stalls of various companies have various elasticity. The one which gives maximum stock elasticity is Tubigrip. So use Tubigrip, suture it into a finger stall and roll it over the fingers. So yes, it does give compression. And if you have access, the one that is American is called Coban. So sometimes it's available in this part of the country also. So you can get Coban, but a cheap and effective thing is stitch up Tubigrip, and that works. So does that answer your 3 questions?
Yes, sir. Yes, sir. Thank you very much. That's very helpful. Thank you.
Yeah, my personal opinion is that splints should be managed by hand surgeons. We should not depend on all these thermoplastic splints and all the other fashionable thing is only, I think, increasing the importance, or it is used by the physiotherapists and OT people to increase their importance. That
Yes,
splinting is so simple. And what we should do as a hand surgeon is we should devote more time, as Pankaj Ahire has very rightly said, that we should devote more time. Don't charge them. Don't charge them in the OPD. Make them wait. And now, because of our lockdown, we have learned, and patients also have learned to send us their details on WhatsApp. They can be asked to show how they are wearing the splints. They can be asked to show how they are moving the fingers. If they are far away, they can be asked to follow up quite frequently if the pandemic permits. So I think splints and their application should be handled by a hand surgeon only. It is only for the occasional hand surgeon who wants to operate, and then he wants to, I would say, use a splint. Then he doesn't know about it. So that's why these lectures are very important. In fact, we should have more detailed discussion on splints, and individual fractures should be treated, or we should show how individual fracture has been managed, the outcome with the help of a splint. At the end of any fracture treatment, we should show the application of a splint. Minor things like flexion contracture, extensor lag, stiffness, scar contracture, scar adhesions, how they can be also managed on our own, this thing, in our own setup, or even in our OPD without the help of any other modality or specialty. I think that will go a long way in reducing morbidity of hand patients.
Can I ask one more question, please? See, we see ulnar sided wrist pain as a very common problem in clinical practice. And a lot of times proper splinting and proper support, especially in terms of restricting pronosupination, can be very helpful for these patients. However, I think Parag mic is on. However, we find that the splints can be very cumbersome, especially if they are above elbow or the Munster kind of splints. So does the expert panel have any tips or any ideas how we could better prescribe or make splints that would be beneficial for ulnar sided wrist pain? Thank you.
Yeah, one more comment I would like to make is I always tell my patients, especially who require rest, especially in the query that you raised, Abhijit, about ulnar styloid pain or ulnar sided pain, is that many of these people are from the younger crowd who want to do gym and who want to do push-ups and pull-ups and increase their so-called fitness. I tell them, when they start getting this pain, pain on the lateral epicondyle, ulnar sided pain, what they require is rest, which nobody is willing to accept unfortunately in today's era and age. They want all 4G treatment, 4G speeds in the treatment also, which is not possible. And very important thing we must highlight to all the patients, that you cannot get rest in a medical store. They are willing to spend on thermoplastic splints and on various sorts of treatments and injections and drugs and all those things. And they immediately, at the drop of the hat, they want to go to a physiotherapist. But nobody is willing to take rest, which is probably the most important treatment. And I think we should highlight that, or we should remember that and highlight that to our patients also, that you cannot purchase rest in a medical store. Yeah, any Pankaj, both Pankaj? Yeah, Pankaj Aire.
Yeah, absolute words of wisdom. I think rest is a underutilized modality. I do emphasize, try to emphasize on rest the way Sir said, and I found that it is of immense benefit to the patients. One tricky thing, not one unhidden advantage of splints, I find, which is also documented in some of the papers, is immobilizing the joint proximal. So if I have a patient who needs good mobilization of the metacarpophalangeal joint, it is not uncommon for me to prescribe them a cock-up splint, so that the patient's focus is now on the movement of the MCP joints, and there is no false movement of the wrist joint that is happening when they're attempting to move and they say, okay, I'm getting better. So I found that blocking the proximal joint helps. So whenever I want good mobilization, active participation from the patient of the IP joints, I will try and immobilize their MCP joints, preferably in flexion. However, I came across a very interesting paper recently where a plaster applied to a wrist and hand with wrist in neutral or slight dorsiflexion, and even with MCP joint extension to facilitate good IP joint flexion and edema reduction, has yielded fantastic results. At the end of this talk, I will share this paper with everyone, and then the organizers could share it with the audience. The important thing is using splints to your advantage for edema reduction and effecting mobilization of the joint that you want while immobilizing the joints which might be absorbing a lot of movement on their way. So this is IP joint and this is not IP joint movement. So same splints used for different purpose intelligently will give very good outcomes.
Yes, I purchased a full length of the thermoplastic splint. I think it costed 9,000 rupees and it just became stiff, brittle and broke off. I never used it. So that has been the utility of the splint, because it's cumbersome, it's a waste of time. It looks very attractive and good, but it's useless splint because there are better material like aluminum or rubber that I've been using. So it doesn't serve the purpose, honestly. It looks good. It's aesthetically better. That's all. So you can use it for a day, but next day give a splint that I have been talking about.
I find that sorry to interrupt. So I completely second what you're saying. A lot of times the rivets that are used in these thermoplastic splints, because it becomes so rigid, they start becoming pressure points, and the patients are pretty much at a discomfort and are annoyed by those rivets, in fact, and the finger, the edges could also cut into the skin. So you've got to be very careful with these thermoplastic splints.
And coming to mobilization, yes, sometimes, not always, early time, other than the rest, what has helped is strengthening the supinators and pronators. So with the elbows flexed, I'll encourage them to strengthen their supinators. I think there was a paper presented during IFSSH where the treatment was purely on ulnar-sided wrist pain, conservative management. And the author highlighted strengthening the supinators. And there was, during the lockdown, I read one on physiotherapy, strengthening the pronators. So pronator quadratus against resistance. I've seen sometimes it does help when in early cases. If it is not helping, then of course there are other modalities here.
Another thing which I find is that the first thing orthopedic surgeons do is to jump to an MRI in a ulnar-sided pain. And unfortunately, the MRI always reports as a TFCC tear or some lunotriquetral cyst. And that cyst unfortunately finds its way into the patient's brain. And then they start pestering us, ki ye cyst dikh raha hai, abhi kya ilaj hai iska? So that is, I think we should examine the patient first in great detail. There are various causes of ulnar-sided pain apart from TFCC. And one of the, I think the most commonest cause is extensive carpi ulnaris tendinitis, or what is also popularly referred as a reverse decurvence. There are definitely other conditions. We should, I think, examine the patient for DRUJ problems. We should ask the history whether there has been a twisting injury, and probably then have a look at the proper X-rays, MRI, probably. And of course, Abhijit, your specialty also will work in this arthroscopy. And I think it would be interesting to hear Anil, because after prolonged surgeries and because he is going to follow up the patients for a year or so, 1 or 2 years, I think he must have had good experience about splinting, because he will definitely require splint till the patient recovers. Anil?
Hi. Generally, I don't use splints in paralytic upper limbs because the limbs are insensate. And if you don't take care, I've seen ulceration over the dorsum of the wrist because of prolonged application of splints. So I'm not keen on putting splints alone in paralyzed upper limbs.
Okay. Should I?
I encourage the patient to maintain passive mobility. I pointed out to them that mobilization is not painful. And then I counsel them on the proper position of the upper limb.
Okay, but
I do not.
Sorry to interrupt you. Do you go for plasters or thermoplastic material or aluminium splints or locally available material, if at all?
I am totally against putting plasters on a paralyzed upper limb because that adds to the weight of the limb.
Agreed.
And therefore, I am very keen on form-fitting thermoplastic splints, but they are always made in my presence.
Good.
So till I finally certify that this is what I want, it is being made in my consulting room with a water bath in my room. Okay. The splint maker comes and makes it, but I insist that it's made in my presence.
Yeah.
Otherwise, the patient goes with a prescription, gets it made, they send me a photograph. I find that it's not suitable, and I'm not able to communicate with the splint maker exactly what I want.
Right. So that exactly goes with Pankaj.
Yeah, just a small comment about paralytic hands. I think the commonest paralytic hands in practice of non-brachial plexus type of hand surgery practice is a radial nerve injury, in which we were always taught that, support the wrist, there is a wrist drop, it will become stiff. Somehow, even though patients who never used these splints and presented 4 or 5 months after the index problem, I've never found their wrists to be stiff. And I also found very interesting, very early literature about splinting in nerve injuries, where one of the reasons for splinting the wrist in extension for radial nerve, because I think most of the study of the peripheral nerve trauma started with radial nerve injuries. One of the reasons said, if the paralyzed muscle is allowed to stretch beyond its physiological length, even when it recovers, it will never recover to a useful strength later on. Therefore, one of the reasons for splinting a paralyzed limb is to prevent overstretching of a paralyzed muscle, so that as and when the reinnervation happens, the muscle regains better power because it has not been stretched beyond its physiological length. I found it wonderfully logical. Of course, it was a very old, well-substantiated paper, and it does work in our practice as well. That is point number one. Point number two was again a 100-year-old paper by Caneval on hand infections, and there he mentions about the role of splinting in infections. It could be a deep forearm infection, it could be a fasciotomy that you have done and the wound is open, it could be a contaminated wound. He says all open wounds, all potentially infected and contaminated wounds should be immobilized, because one of the ways that the infection spreads from one part of the compartment to another, or one compartment to another from proximal to distal, is through lymphatics. And if you do not immobilize the limb with a continued movement of the functioning muscles, the lymphatic spread of the infection happens. And one of the ways to contain the infection is to immobilize the affected compartments of the forearm and hand. Remember, this was in the era of pre-antibiotic era. So they needed to look at every possible way of preventing infection. So is the importance of splinting. Thank you if I stretched it a bit too far. Sorry if I stretched it a bit too far.
What about Hemant said about this TFCC and MRI? There was a paper, a German author, Kai Megerle, and he compared clinical examination with MRI with arthroscopy. He says the worst thing is the MRI. It just does not correlate. And therefore, just don't jump because MRI is the positive. So it may be a coincidental finding.
So I think you have made two enemies today, Pankaj. One is physiotherapist and one is a radiologist.
No. I always send a physiotherapist, but as I say, don't listen to them. An MRI, you get the MRI, but don't look at the report.
Yeah, I think we need to be fair and gentle to the to the radiologists who are now getting into the wrist MRIs. I'm sure there will be a stage will come when MRI reporting of the wrist will also become very accurate. Another thing that needs to be done for better MRI reporting is a to and fro communication with the radiologist.
I think that is.
Yeah. So every time I order an MRI or detailed clinical examination, what I am interested in seeing is written. Once I get the MRI report, and if I have operated on this patient or I subject this patient to arthroscopy, I share back my findings with the radiologist. And this over a period of time has refined our understanding of wrist pathologies much better. So very long association with the radiologist, mutual respect, and allowing each other to learn from each other's findings is what is required to best utilize the wrist MRI.
Yeah.
But you would require a 3 Tesla MRI with a dedicated coil. So if you get a 0.75, then it's an embarrassing situation. You ask for a second MRI, the patient says, what's your personal interest now?
Yeah. So with 3 Tesla on dedicated wrist coil is what I love. That's what I order. If not, a 1.5 Tesla on a dedicated coil. If not, a 1.5 Tesla MRI that has been reported by a radiologist, re-reported by a radiologist who is familiar with the wrist. If not, my clinical findings and arthroscopy if required.
Yeah.
Can I just butt in?
Yeah, please, Anil.
I just wanted to update on Pankaj Ahire's comment on splintage to prevent overstretching of the paralyzed flaccid muscles. Yes, this point was the purpose of the famous radial dynamic cock-up splint which is literally imprinted by default setting in the prefrontal cortex of every orthopedic surgeon in India. It is a complete misconception because it dates back to the era when nerve injuries were not being repaired. Okay, they were waiting for spontaneous recovery, and in that endeavor were waiting for months and months. Now, what we are looking at is essentially to support the MP joints without letting them drop too much. The wrist should be in a functional position. The intrinsic should be encouraged to extend. If the patient keeps wearing that hanger all the time, then his MP joints are going to get stiff in hyperextension. So the fact that those loops for extension of the MP joints was only to be employed when the patient is actively flexing the fingers is never impressed upon the patient. And therefore, the radial dynamic cock-up splint is my sworn enemy in terms of radial nerve injuries. I would prefer what is a very low profile reverse knuckle bender splint, which is made of very lightweight spring wire, and the patient MP joint is not supported in hyperextension, it is supported in neutral position, and the patient is encouraged to flex against the spring wire so that the finger flexors remain strong with a view to future tendon transfers. So that application of the splint for the radial nerve palsy is acceptable. Otherwise, I would offer just a short T splint to maintain the wrist in neutral position and let the patient continue using the thumb and fingers.
Yeah, thank you. Anil, I agree with you. I think one point we should carry home is that these loops which are given as a part of the extender splint should be banned, but they are very cumbersome to wear and most of the patient carry them in their bag. I see Dr. Ghodke ready for his presentation. Abhijit, can we ask him to present it now?
Yes, sir. Does Pankaj want to make a quick point?
Yeah, sorry. I didn't see you.
Yeah.
Pankaj. Sorry.
So Dr. Bhatia, all points taken. My point was the misconception that we used a splint in radial nerve palsy for prevention of stiffness. We perhaps do not. And I completely agree with you about the metacarpal loops. I've stopped using them for almost now last 10 years. What I use is a cock-up splint just to keep the wrist in extension, and that also helps the rest of the extensors from overstretching. Completely agree with you about the MCP joints being held in extension by that loop and not serving any purpose. Absolutely.
I think, Pankaj, I think these metacarpal loops have been given to a patient only by a physiotherapist. As an orthopedic surgeon, we never have ever used metacarpal loops. I don't think Dr. Jindal, you, Anil, anybody uses them. They have been given to, if the patient has been referred to a physiotherapist for a splint for radial nerve palsy, he always gets these loops. So we should ban them, I would say.
I was occasionally using them for extensor tendon repairs over the dorsum, or
even then your splints are much better.
Yeah, even that now I have virtually stopped with the wrist put in nice neutral moderate extension. I think even for extensor tendons, we may not need to immobilize them in a dynamic splint like that.
Right. Yeah. Dr. Godke, can you start your presentation, please?
Yes. Thank you all. Thank you. After a very excellent presentation by Dr. Jindal and an elaborative discussion over splints, here I am to present about very basic our plasters. So here we are presenting on a application of a dorsal slab. So I have a video presentation for this.
Ghodke sir, the sound is not playing. What I suggest is when you hit on the share screen button, there is an option to optimize the video streaming and computer audio. Could you please unshare first, stop your sharing.
Okay. Right.
And go to the share screen button again.
Yeah.
And then it will say optimize for streaming and share computer audio at the bottom.
Yes.
There are two boxes.
Yes.
Please select them.
Yeah.
And then you share, please. Thank you.
Thank you.
What we are doing
now is it okay now?
Yes, it is. Yes, it.
Yeah. So this is basically we are going back to basics, very basics, that application of a dorsal slab in a functional position. And as Dr. Patankar said, that we should have some videos about all this application. So here I am with a video to present about a dorsal slab.
We take plaster, POP, cotton. This is candid powder so that they will not have itching. Bandage and crepe bandage. Over that we use crepe bandage. These three things we use in the wet space so that it will not get sodden. This is the cover of the glove where we use it inside the plaster. So we'll show that technique. This will be the position. This wrist is in extension and MCP is in complete flexion. So we should always this in the wet.
There is a window that pulled up. We couldn't see your video.
Yeah, just
till here.
Just a minute. I'll again start.
Slab which we apply in the hand or in slight extension. And
am I able to are you able to see?
No.
Now?
Yes.
Yeah. Sorry for the inconvenience.
So this is the James position or functional hand position. So here what we are doing is a dorsal slab. We take plaster, POP, cotton, This is candid powder so that they will not have itching.
Is the video playing, please?
Yes, it is. Yes, it is.
Yeah. Bandage and crepe bandage. Over that we use crepe bandage. These three things we use in the web space so that it will not get sodden. This is the cover of the glove where we use it inside the plastic. So we'll show that technique. This will be the position. This wrist is in extension and MCP is in complete flexion. So we should always keep this in the web space. So this will help in avoiding the soddening which usually happens due to sweat. Put the cotton roll. It will go till here. This is the cotton roll which is applied. Common with plasters. This is another very important thing. About the position, it is very, very important. So again, this is wrist is in extension and fingers are in complete flexion, thumb is out. Complete flexion at MCP joint, so over here. So the plaster will come like this, like this, like this. जसं साप असतो ना तसा हात ठेवायचा सापासारखा असं. Okay. The glove cover and over that there is a cotton roll and now we are preparing the slab. So the slab is prepared as usual. So one more thing what we do in this is we make this thing. So this makes the plaster 4 times strong. So this particular thing. And over that now we'll do this. So now I will cover it with this. So again, important thing is about the functional position. I'll just hold the plaster there. So the advantage of a POP is I can mold it till it gets set. I'm very happy to give slabs with POP rather than RT cast. And the cast thing I always try and use RT cast. So slab with a POP to me finds that we can mold it to our desired position. What we call it as a temporary plaster, so we can later on change it into a RT cast. So again, the functional position is very important. So what I ask is I will ask them to hold this and daba. So with this, my fingers are in good flexion, and till the plaster is set, they will hold this cotton roll which is remaining, and then I can do the molding. I can do get my desired functional hand position. So you can see here, it's a very good functional hand position. So the fingers has to move, right, so that they will not have stiffness, they will not have loss of motion, which is very, very, very common. So the idea is we should not, whenever we are putting a cast, the cast should not cross this distal palmar crease, because your MCP joints are exactly over there and you get a lot of stiffness if the cast is crossing over. But now this is a slab, so in this slab what I am trying to say is there is good MCP flexion, that is 90 degree, There is extension, and the other IP joints they are able to flex. So now the plaster is getting set. It is almost set now. So this is the desired position what we get. So the fingers are free. Asakara, asakara, swarakara, asakara, hamba. So now one more thing what I do is I always cover it with a straight bandage. Yeah? So it looks good, number one. Number two, the bandage doesn't get loose. That is the norm. That is the usual problem what we face in a slab. The bandage becomes very loose. So that is what that is why we apply a straight bandage. So this is again important. Look wise also it is looking fairly decent. So you can see this ridge what we have prepared. So this ridge makes it almost 4 times stronger than a plaster without ridge. So this is done. And normally in all these plasters, we don't keep it at 90 degrees. We see to it that it comes over here. So the injury should be at or above the level of heart, so the swelling and all the things will reduce. So the typical cuff and collar what was started is the button on the cuff should go onto the collar. So that is what is been taught or is been prescribed to us. So this is what is dorsal slab, and thank you.
So this is what we have shown is the basic, very, very basic of orthopedics, applying a plaster in the wrist and hand injuries or even your post-op management so that we can have good hand functions later on.
Yeah, Ashok, it was a nice demonstration, and I think you highlighted some very important and very essential points. First one is that apply the slab dorsally, and secondly, never cross the palmar distal palmar crease, which is very important. I think these 2 points should be highlighted in I would say italics and bold both, and highlighted, and I think we should shout from the rooftops. But these are the commonest causes of stiffness, and it was a very nice I would say demonstration of how to apply a slab and how to prevent stiffness related to slab. Also, you have made a very good point about elevation of the hand about the level of the heart and keeping on moving the hand. It was a very good presentation. I think you have highlighted exactly what we require to prevent plaster related complications. Pankaj, your comments. Dr. Pankaj Jindal, your comments.
Dr. Jindal, sir.
I don't apply that antifungal. I don't know if that's a common application for all of you, but I don't use. I don't apply candid powder.
So basically, they keep on complaining of having itch, and so that to make some mental satisfaction, we just apply that so that they will have less itch inside the plaster.
Okay. Do you apply Hemant?
Even if
no, I don't.
Okay. Abhijit, you use candid?
No, sir. We use a stockinette and then a soft roll on top.
You use candid?
No, I don't.
No, I think in our Bombay, Panvel area, whatever you do, patient is going to sweat and he's going to suffer from this humid climate. In Pune, probably the climate is much more better. So patients will not have this problem. It is a problem, and I don't use the powder, but patients do complain of itching and irritation.
Ashok, try using talcum powder instead and see what happens. You don't mess up with the internal milieu and use antifungal. Just see and let us know.
Right. I will do that.
Okay, good point. Yeah, Pankaj.
Yes, some very simple points that were present in the video, which I feel deserve to be highlighted. Every time any circular bandage is used, whether it was a cotton bandage or
Normal.
the cotton padding or a normal bandage or a crepe bandage, always start from distal to proximal. Very simple thing. As a rule, always follow. If you start from proximal to distal, chances are that you could encourage edema formation. When you are using the bandages, ensure that there are no constrictions that are being formed every time. Whenever you are using a plaster, ensure that there are no constrictions being formed. I think these are very subtle points which were present in the video, which can go a long way in preventing edema formation or undue pressure points in the plaster. Thanks, Ashok. That was a very wonderful video.
Thank you.
Can I make a comment?
Yeah.
Yes.
I have stopped putting gauze pieces between the fingers because that once it dries up, it acts as a constricting element and increases the edema of the fingers. If there is no wound in the webs, I encourage the patient to clean the webs every now and then. The example I gave to the patient's relatives is that I asked them how many times do they wash their hands in a day, and they say that they wash 10 to 12 times in a day. Then I say that why is the injured hand, where there is no wound in the web, not being cleaned? So it is the patient and his relative's duty to see to it that there is no maceration and sweat and smell coming in from the webs, rather than relying on a gauze piece. Because if the minute you put something, then the patient is not going to touch it, because he doesn't want to offend the surgeon or offend the treating doctor by disturbing what the doctor has put. But if you don't put anything in the first place, which is not required, there is no wound in the web, therefore there is no need for a dressing there, then keeping the webs clean and keeping them dry becomes the patient's responsibility, and then he will be more comfortable with the splint and with the brace, because he knows that he can touch portions of it. Therefore he will learn to keep the bandages off the distal palmar crease. He will keep the webs clean. He will keep flexing the fingers. The minute most often what happens is that if the patient has a plaster put by us, even if he keeps it dependent for a few minutes, it tends to slide a bit distally. It crosses the distal palmar crease, and then the MP joints start getting stiff and extension. So if we encourage the patient to participate in the management of the plaster, then I find it more helpful.
Yeah.
Also, I find the quantity of plaster being put on the dorsum. I mean, if you are going to make a dorsal ridge, I don't think you need 2 full plasters in the dorsal plaster slab. Quite often, I have been able to manage with fewer layers of plaster. But I mean, that is individual. That is up to you.
Yeah, I think point well taken. Can we ask Dr. Parag Lad to speak now?
Yeah, good evening, sir. Because I'm working on my presentation I will be delivering on 4G, no electricity at home. So I will not start my video. Am I audible?
Yes.
Yeah,
yes,
you are.
Yes, sir. And is my screen visible?
No, your face is visible.
Oh, okay. Okay, sorry, sir. I will share my screen. Yes. Is my screen visible, sir?
Yeah.
Okay. Yeah. So I would like to present a case of I would like to present a case of 34-year-old female, and she had fractures of the index and middle finger base due to fall from bike. So the fractures were not that, I mean, that was one of the concern, but the other concern was she was in her first trimester of pregnancy, and she had conceived after a IVF treatment. And for, I mean, she had given us a challenge that we should do the surgery without using CM, because she got conceived after 6 years of marriage and IVF treatment, and this X-ray was obtained after using abdominal lead sheet. So this patient, I mean, I had done the surgery without using CM as requested from the patient, and I had explained to them that there is a possibility of malunion, but then I did not use CM, and this was my fixation. So I would like to go further, and this was 3 months follow, and she was into her second trimester of pregnancy, and probably my middle phalanx, proximal phalanx of middle finger screws were too long, and that's why, I mean, the screws were palpable, and I was really worried that probably I have injured the flexor tendon, and that's why she is not flexing the middle finger. So now, because she was in her second trimester of pregnancy, I advised her to consider implant removal and look for the the continuity of the flexor tendon. But the flexor tendon looked completely intact, and I had to do a flexor tenolysis, and this was the result at 2 months from the flexor tenolysis. I mean, post tenolysis, she had reasonably achieved a good flexion. But after that, I was worried. I mean, I was relieved, and there was no follow up later on. But then, 4 months post flexor tenolysis, and now 2 months post pregnancy, patient again developed a stiffness. And now this was the case where the family wanted to sue me, because I had to do the second surgery, and now they explained me that you were talking about malunion and non-union, and you never told us that we may face this complication. And it was really I had to face sleepless night for few weeks. Now at this stage also, I had offered a surgery again to consider. I had done a sonography at this stage, and my sonologist mentioned that the flexor tendons were completely intact, but there were adhesions because of the plate. And again, I offered them a surgery, and I gave them options of all senior hand surgeons in the city. But then, because they wanted to get it done free, then I had planned for extensor tenolysis, and now this time under local anesthesia. So I had considered a mid-neutral approach, and under local anesthesia, I did a gentle manipulation. And then this was the finding intra. I mean, this was the video under anesthesia when I manipulated. There was around 0 to 60 degrees of movement possible. But then I did a mid-neutral approach, and then I did I found there were adhesions around the extensor tendon, and then extensor tenolysis was performed with the mid-neutral approach. Flexor tendons were reasonably, I had to make them free with the periosteal elevator also, and they were stuck to the proximal phalanx shaft also. And then this was the immediate post-op result. So the message I wanted to give here is, the tenolysis can be also considered in the local anesthesia, or in the under digital block, and or nowadays under wide awake local anesthesia and no tourniquet. This surgery, patient tolerated the tourniquet also well for 20-22 minutes. And right now, I don't have a follow-up at 3 months, but now definitely they are away from me now, and they have got the full flexion of the finger, even at the middle finger. So this is the case that I wanted to present. So mid-neutral approach, I did an extensor tenolysis. So this was the flexion, active flexion under digital tourniquet. So my message is, tenolysis of the flexor and extensor tendon, that can be considered, and it has proved to be beneficial if we consider it under when the patient is awake and under local anesthesia, or wide awake local anesthesia with no tourniquet. I am happy to discuss the case again. Thank you. Thank you very much.
Yeah, Parag,
Can I
it's
ask a
a nice
question?
case. Lots
Yes,
of
sir.
other challenges also in that case. And I think you have highlighted
Hello.
two very important features of fracture of the
Hello.
proximal phalanx. And that is,
Sir, I cannot hear you. Hello.
yes,
I cannot hear you, sir. Now I can hear you. Yes, sir.
yeah, it was a nice case demonstrating a lot of challenges faced by you, is you in spite of other challenges, in spite of the fractures of the proximal phalanges and the problems of flexor tendon adhesions and extensor tendon adhesions, especially following the use of a plate. I think you have highlighted very well. And I think we must consider this and probably warn the patient in advance. That is what I think a lesson we can learn from you, that in addition to malunion, we have to warn the patients about tendon adhesions also.
Yes, sir. Sir, may I know you
Dr.
all
Jindal
of
and Dr.
your choice of fixation in this case?
Pardon?
May I know all of your choice of fixation in this case and in this scenario? How would you treat, or you would treat in a traction and splint in flexion that you always show?
No, no. I would also operate this. Maybe I would not have C-arm and use of this thing was probably perfectly valid, but I would not use a plate in this case. If you have used a plate in the index finger, I could have cross K-wires. I would have used the same treatment because plates are known to be causing adhesions, especially in phalangeal fractures. Metacarpals you may get away. I don't think the problem was because of long screws.
Okay.
I think the problem was because of the uh,
Plate. I mean,
angulation at the fracture site. That was the primary cause. Long screws may have contributed. I don't know exactly how long they were, whether they were really going to the tendon, but they would not go into the sublimis tendon. They would
yeah.
probably interfere with the profundus tendon if they are so long. But I
Okay.
would use cross K wires in this or retrograde K wires. I would not
Okay.
use a plate in this particular case or in these fractures
Okay.
unless the combination or the other factors dominated the scene.
Okay.
But
Okay.
adhesions of flexor and especially flexor tendons with the severe angulation that you had pre-op
Yeah.
was the cause of the flexor tendon problem. And
Yes.
extensor tendon was only due to plate. I would not use a plate in this, but I think you managed it very well and it was a good result.
Yeah.
In this also, post-operatively, I would advise you to
Yeah.
use a two finger or three finger strapping to encourage more flexion post-operatively after the second surgery also.
Yes, sir. Sorry, I missed it, sir.
Yeah, Dr. Jindal?
Yes, I agree. I would have fixed with K wires in the middle finger also. And the problem was with the extensor tendon adhesion. My incision would have been dorsal. Did you use different incision for plating and for lysis?
Yes, sir. My plating was from the dorsal incision, sir.
Any reason why you preferred to have a lateral incision? Because it's almost difficult to go on to the other side, though your
So,
wound is healed, but
yeah.
the strip between the previous incision and the new incision, the
Yes,
strip
sir.
is a potential trouble there. So I
Yes,
would have
sir.
preferred to go through the previous incision.
Yes,
And
sir.
something
I
about
mean,
was on the flexor tendon getting adhesions.
so my only the reason for taking a mid neutral incision is I wanted to look for the flexor tendons again. That in the second surgery,
So
I
can I
wanted
ask, how was the passive flexion of the finger?
passive flexion of the finger. The 0 to 30 degree movement was possible, sir.
So if there was no passive flexion, obviously I would think since you can show full extension,
Yeah.
my guess will be the patient had extensor tendon adhesion.
Oh, okay.
And the next thing, what was your post-op, if I can, if you permit me, what was your post-operative regime after the plating primarily?
Oh, primarily, I immobilized them as Dr. Godge showed, immobilized them in a dorsal slab up to, I mean, by 90 degree of MCP flexion and started finger flexion immediately. And then at 3 weeks, at 4 weeks, but because she was in pregnancy and she was advised bed rest because of IVF treatment, the follow-up were also, I did the suture removal at 1 month after the surgery, sir. So that was also a small challenge also. But then when she came to me, she was already stiff. And then I was understanding. I initially thought because my screws were long, and I thought the possibility, I mean, I did the sonography again, but I thought the problem is on the flexor side only because of my screws.
Can I ask a question, please?
Yes, sir.
This is Abhijit here. Parag, we know that the radiation from a C-arm is perhaps lesser than that of a single X-ray or one chest X-ray. And would it have been possible, and this is just a question in hindsight, that we are compromising on our own security perhaps and safety for some challenges that are posed. So couple of questions. Could the treatment have been postponed a little bit till such time that it would have been safe to take the patient up under C-arm control? Two, would you have considered putting 1 or 2 lead gowns in the operation theater on the abdomen to prevent radiation exposure? And maybe 1 or 2 shots would have been sufficient for you to do a cross-K wire.
So first option I had discussed with the patient that I would now just give you a slab and let it malunite, and we will tackle it when everything sorted out in your second trimester. But because the angulation was so bad, and I mean, it was unstable. I gave a digital block in casualty, tried to reduce and give a slab, but she came back in 48 hours saying it is unbearable pain. So, I mean, they convinced me for the surgery. I had given them an option of that. Second, the purpose of using the plate is because I did not have to, I mean, that was the only reason, because if I put a plate, I don't need CM to put a plate. And second question that, sorry, your second question that you mentioned is using a 2-laid apron.
Yeah.
So I discussed with the gynecologist and radiologist that can I do that? But then they said the honest is yours and you decide. We don't know. I mean, I tried to search the literature also, but I couldn't find. And radiologist said that, of course, the risk is involved, but definitely lesser. But how much lesser and how much that nobody was ready to accept or nobody was ready to assure me. In fact, I discussed with the sonology who did their amniocentesis and this that, then he said it is, if you just postpone the surgery, that is the best option.
Catch 22, and treatment of a stiff finger is one of the biggest challenges and a nightmare for any hand surgeon. Thank you
And
very much.
I forgot to mention that she was a left hand dominant lady.
Double
So that was
whammy.
another reason for me to again accept the challenge and consider surgery for her.
But she had a successful pregnancy, no? Then
Yes, very much, with successful functional hand outcome also, sir.
Successful pregnancy and successful surgery also.
Surgery, I mean, she became better 9 months post surgery. I mean, but I was happy
Interesting. What was the mode of injury?
She was a pillion rider behind her husband, and she fell down from a bike because the dog came in between, and while falling to support the fall, her finger got hyperextended. I mean, she had a fall from bike.
Okay, so she was riding pillion on a bike.
No, she was sitting behind her husband.
Yeah, riding pillion on a bike.
Yes.
While she was carrying a precious pregnancy.
Yeah, true.
Can I butt in for a minute?
Yeah.
Hello?
So I think we have to be very careful about trying to do the best for patients who may not be ready to receive the best. So
can I make a couple of points, please?
Yes, sir.
Hello.
Yes,
can you hear me?
Yeah, Anil.
Yes, sir.
Yeah. See, there are 2 things which I was disturbed about. One, that you tried to do passive flexion before you did that extensor tenolysis. See, if they are suspecting that the extensor adhesions are limiting your passive flexion, then before you have mobilized the extensor tendon, you are doing passive flexion under anesthesia. You are merely stretching the adherent extensor tendon. Therefore, it is not a wise idea to do passive flexion at that stage. Once you have freed the extensor tendon under local anesthetic, you can do passive mobilization to get full passive flexion, and then ask the patient to take up the slack by doing active flexion. Tenolysis, even the flexor tenolysis originally should have been done under local anesthetic, and that is something I shall let pass. But the extensor tenolysis, before you did the tenolysis, you did passive flexion. That was a definite no-no. The other point I wanted to raise was that nobody has made any mention of the probable injury to both collateral ligaments of the MP joint of the ring finger. There are avulsion fractures at the bases adjacent to the head of the fourth metacarpal seen on the X-ray throughout. I was wondering what is the condition of that ring finger?
So I would like, no, sir. I mean, that was notified, but I did not consider any surgery. I mean, or any stabilization. If you see, this was the last video after tenolysis. Even there is a restricted.
No, the MP joint is not flexing.
Yeah, the MP joint was stiff in that position. I mean, in the ring finger.
So that is exactly my point. That throughout the collateral ligament injury on both sides of the MP joint of the ring finger has been missed.
Yes.
Yeah, I think Anil has made a point.
Yes, sir. Yes.
And I think we are having lots of speakers remaining. Can I ask Samrat to, Dr. Samrat Tauri to give his presentation?
Just a second. Am I audible, sir? Am I audible?
Yes, you are.
Yes, you are.
Very, very good evening. Thank you, MOA, and thank you, Abhijit, sir, for this opportunity. I'll start with my basic topic is on digital tourniquet technique, but I'll share a few other aspects. So we started with the battlefield where such type of tourniquet was used to stop bleeding. And this is a historical petit type of tourniquet. And this is still used in emergencies as a first aid. But my topic is on digital tourniquet. Start with acknowledgement. I thank Dr. Hardikar here because in my first month of my residency, on the first year, the first topic which was given to me was tourniquet. And this is the book which we all know. And then the other institutes, Government Medical College, then I learned a few things about tourniquet, which we'll discuss with Dr. Jindal. Then our next hospital at Indira Gandhi Government Medical College, and then Vellore. Why I'm mentioning this, I'll just present in a minute. So in our residency, we did almost everything under automated electric pneumatic tourniquet. We just did not know about the pump tourniquet at that time. After that, when I went to Government Medical College, we did almost everything under automated electric tourniquet again, but few times we used pump tourniquet. The pump was not good. It did not have a good calibration. That's why we were not generally using it. After that, I went to work with Jindal sir, where I saw a lot of work with pump pneumatic tourniquet. And the second thing I learned was that it can be used in the arm and as well as in forearm. More importantly, that was a basic training where I was taught that everything has to be done with tourniquet. From there on, I went to Indira Gandhi Government Medical College, where again, we were using the automated electric pneumatic tourniquet, but I had at that time acquired a pump tourniquet with myself. It was well calibrated and I was using it for arm and forearm for simple things like ganglion and for decurvin in our college. But my recent experience was that when I used the same tourniquet on my hand while preparing this presentation, I could not bear the pressure of 150 millimeter mercury for more than 1 minute 40 seconds. I don't know how patient used to do it. And that was in the arm. And now my tourniquet is out of order and I did not find anyone in Nagpur who is doing a repairing this pump pneumatic tourniquet. Why I'm searching so much is because I want to stress on the point that if you are using this manual pneumatic tourniquet, it has to be well calibrated. It has to have well serviced if you're using it. And if you don't have it, don't need to buy it. Digital tourniquet was something which I used earlier, but mainly I learned about the basic technique of it, the important technique of it at Vellore. I'll come to it. And there only we learned something about BP apparatus to be used as tourniquet. I've never used a smash as a tourniquet and should not be used also. So this is the topic. In the digital tourniquet, there are numerous techniques which have been described. This is the Salem technique where a finger glove is worn on the finger and then a small cut is made at the tip of it and it's gradually rolled down so that it forms a ring which is constricting here and it exsanguinates the finger as well as it forms a tourniquet here. The other part about it or modification of it is, of course, the one important thing is that we need to have a clip here so that we don't miss to remove this tourniquet at the end of the surgery, because generally the fingers dressings will be probably up to here, or it may be covering even the hand and wrist. So put a clip here so that we don't ever forget to remove this tourniquet. The other modification of it was that we put a clip here, and then we cut this part of the rubber, the gloved thing here, so that once the clip is removed, the tourniquet automatically gets loosened and it doesn't stay there. I'll come to it. But so when I was working in for myself, and this was a crime which I did. This is 2010. So tumor completely removed, very enthusiastic to do hand surgery, 2010. And I did this, and I'm really sorry to all the panelists. This I did only once in my life and I've never done it again. Highlighting it here because this type of catheter, any catheter or any such tourniquet is real no-no. So that should not be done. Some review of literature. So all these catheters cause a huge pressure, about 800 millimeter mercury, and they should not be used. A surgical glove tourniquet, as per this study, was about 360 millimeter mercury, and that was acceptable. So that should be used. No other catheter or something should be used. Another thing is that generally the digital tourniquet is suggested for 15 to 20 minutes. And so we need to choose those procedures which we will be able to finish in that time to opt for digital tourniquet. Contraindications are same as any other tourniquet, peripheral vascular disease, sickle cell. Whether we can use tourniquet in infection, we have to look at it case by case. I'll come to it. If we are thinking about a tumor which may cause seeding, then we should not use a tourniquet. If there's a foreign body which may cause a major problem after when we use a digital tourniquet, we should not use it. And those cases where we are not sure about the how the extent of the surgery may be, whether we may have to go up to the dorsum of the hand or on the volar aspect up to the palm, then this should not be used, because ultimately we won't be able to do a good hand surgery without tourniquet. In that case, it's better to use a forearm tourniquet, or best is to use an arm tourniquet under full complete anesthesia. Few other techniques which I found interesting was, if there is a lot of contamination in the hand and we are doing one finger on a basis, one finger each, then what they have shown is that they would put betadine in this sterile glove. After draping and complete preparation, they would put betadine in this glove and ask the patient to wear this. This is after giving digital anesthesia here. And then they will cut it on the slit like the Salem method, roll down the glove. It will act as a tourniquet. At the same time, it will maintain a sterile feel. Just, I find it interesting. So this is the video. And I'm sorry for the lighting and probably few things won't be clear here. So I use 6 or 6.5 size gloves. These are not always the fresh gloves. Generally, the anesthetist or the staff may be using it. These are generally unstained gloves, and it can be washed and then used in our autoclave. So they are autoclaved in our with our instruments as such. So anytime we get an injury where we require a digital tourniquet, then we can use it. Also, I have seen at centers where rings of these gloves are kept in the formalin chamber and then it's used. I think that that should not be done because it is not very costly thing. Even a fresh glove can be used. So I cut it here. We are discussing about the middle finger. So when I'm doing this, the assistant will be taking a clip and putting it here to pull it, because it just gets slipped when we try to roll it down. We pinch it good enough so that we don't injure the fingertip, which is already injured. And as we roll it down, it exsanguinates. And this has to be done when we are ready with everything, because the time we have got is about 15 to 20 minutes. Many times there is some laceration. Okay, I'm sorry, let me finish this. So the clip remains whole time. And when we remove this tourniquet, it should never be done with the scalpel, which is very much readily available on a trolley. Need to never use a blade for this. Use a proper scissor or suture cutting scissor to remove it. And that's the end of the tourniquet time here. Many times there is injury and there's bleeding, and the one tourniquet may not suffice, or it just slips off, or our glove may be, the finger may be thinner. We may use two tourniquets. It improves the exsanguination. So two tourniquet, two gloves I have put, and then I've used a tooth forceps to turn it in. So once or twice we need to use a tooth forceps, and then we can just roll it down and exsanguinate. I really thank and compliment and acknowledge Dr. Anil Matthew from Vellore for teaching this technique in detail. So the cutting is in the same way. There are case reports where finger tourniquet has been left and patient had amputation of the distal segment, but this is very rare, but this has to be taken care of. The clip has to be kept. What I want to highlight here is about the thing that has been suggested, that we put a clip here and cut this part of the ring. This is not possible because many times lifting this up and then cutting a part of this tourniquet, and what happens is that the mosquito or the artery forceps just slips off and the whole tourniquet gets fail. So I'd never pull this up and cut this part. I just maintain a artery here. This is another interesting part. Can I speak for another 5 minutes, sir?
Yeah, go ahead.
Another interesting thing which we had a problem was that how to exsanguinate when there is a lot of injury, how to exsanguinate in cases of infection, if we have to do this, or we are suspecting it to be a tumor which may spread. or a fracture which may get deteriorated, say a pathological fracture. So what this method is that first they would exsanguinate through an edge mark. From here they will use the edge mark, exsanguinate, then use this tourniquet here, clip it, and then release this edge mark. So you get an individual isolated digital exsanguination. I felt that this can be extrapolated to what we used to do, was that we raise the hand for 7 minutes, about 5 to 7 minutes. After complete preparation, we can just milk off here in through our hands. We milk up and try for the venous emptying with the hand raised for about 5 to 7 minutes, and this apparatus ready here, and then we raise the pneumatic tourniquet or a BP cuff, and once we achieve this, then we clip it here and then release the BP cuff of the pneumatic tourniquet, and that method will be helpful for isolated digital exsanguination, rather a digital emptying, not exsanguination proper, and give us a bloodless field with a digital tourniquet and no patient problem or no pain. So applications, we all know, gets a good debridement and a good reconstruction can be achieved in fractures. And I'm sorry, I want to stress here very importantly is that many times we forget, but while removing these the K wires which are buried in the skin, especially for the metacarpal fractures, we take the patient in the OPD or we just on a side table, give anesthesia and try to find it, and at times it becomes very difficult, it becomes messy. And so we need to remember, for even for removing a wire which is not easily palpable under the skin, it's better to do the case under tourniquet. Maybe a forearm tourniquet for a metacarpal fracture or a digital tourniquet for the finger. In children, this is a door jam injury. They are not empty stomach, and you can't give them anything like ketamine or anything. But they, if you convince them well, they are okay with digital anesthesia. Once you give the digital anesthesia, they are comfortable, and it takes about 5 to 7 minutes or whatever, 10 minutes to debride and fix it. Similar is the case here, where the patient was NBM, this patient, we had a problem, it was in the peak of the COVID. We did not want to give any general anesthesia. So the patient was given sedation, digital block, and then the case was done under digital tourniquet. If in cases where we want to do reconstruction and two places we want to do surgery, again, digital tourniquet can be used here. The nail bed graft was used for the nail defect, and that was the result, and we could do it. So in infection, as I was discussing, we can elevate, put a tourniquet around here, elevate nicely, and then put a lock here so that it will act like an emptying of the digit without doing any exsanguination in this case. So I thank you for your patient listening. Thank you so much.
Yeah. Thank you, Parag. Thank you, Samrat. That was a good presentation. You have highlighted the role of the tourniquet in hand surgery, and especially this finger tourniquet. So I think a very good method. And what my question to you is, what surgeries you cannot do with this finger tourniquet? You will not be able to do, or you will not be comfortable doing with this tourniquet. Samrat?
Yes, sir.
What surgeries you would not like to do with this tourniquet?
In cases where I'm suspecting infection along like a infective tenosynovitis, where the extension may be up to the palm region. In cases where we have got a full-blown infection, we would, and in cases where the patient is not comfortable, patient may not remain still. In situations where it may take more than 15-20 minutes, I won't do it. in areas where the skin is very fragile, old age, whether tourniquet pressure, because we can't measure the tourniquet pressure in a digital tourniquet. Otherwise, also it's about 300 millimeter mercury.
Yeah.
In those cases, I won't do it.
Yeah, I think one quick comment from the faculty. I think that we are having 2 more presentations. Abhijit would like to present. So one quick comment, and I think we'll go on to Abhijit because I think we are running short of time now. Dr. Pankaj, any comments?
My question was, Samrat, what was your problem with that PVC tubing you showed in the beginning of your presentation? You had any complication there?
No, sir. Fortunately, I did not have a complication. And that was the post-op I had showed. Yes, sir. The point was that it has been shown in the literature that it causes compression more than the digital one. That was all. I have never used it after that, sir.
All right. Okay.
Yeah, that was a nice review of literature.
Thank you, sir.
Yeah, Abhijit?
Yes, sir. Samrat, yeah, may I request you to please stop sharing your screen? Thank you. And I think Samrat's presentation served as a wonderful prelude to what I'm going to very quickly present on. This is not a very big presentation, and it's what we do prior to applying a digital tourniquet. And this is what we call as an intrathecal digital block. And this was something that we stumbled upon while I was doing my fellowship, and my senior fellow, Dr. Jill Smith, encouraged me to think about this. And we have ever since been using this technique. And it's not new, but just a modification of a technique that has already been described in literature. And this technique is very efficacious. It is very reliable, very simple. Almost anyone and everyone can do this form of digital anesthesia, right from your outpatient clinic to even some operative procedures in the operating block. And although we never published this particular technique, we had the opportunity to contribute to a chapter which was in the textbook published by Dr. Hardikar sir, and was shown in the first slide that Samrat was presenting. So this technique is also called as a flexor 10 sheath digital block. It was originally described by Chew in 1990, but essentially he was talking about a block near the A1 pulley, or just a little proximal to the A1 pulley. And this particular modality of administering anesthesia is as effective as the traditional ring blocks in achieving an adequate anesthetic region. And we have been using these blocks or these intrathecal injections for anesthesia in performing repair of laceration, nail bed injuries, ingrown nails, draining a phelon or a paronychia, some local advancement flaps for fixation of fractures of the phalanges, even for PIP fracture dislocations, glomus tumor for that matter also. Certain contraindications are a compromised digital circulation where there is an obvious arterial injury and you would need a microvascular repair, an infected injection site, or a known allergy to the anesthetic agent. So it's a very simple technique. We use plain 2% lignocaine or xylocard, about 2 to 3 ml in volume. We place the hand supine on a sterile sheet with the palm up, and at the level of the palmo-digital crease, exactly here in the midline, we insert the needle by pinching the skin, and then we go directly perpendicular to the finger all the way up to the bone. And then you just withdraw a millimeter or two, and you inject the anesthetic, and the loss of resistance would then allow for easy injection. And the anesthetic drug will spread through the flexor tendon sheath, and in about a minute or two, the entire digit is anesthetized. So this is a clinical picture of how we administer the anesthesia. We use a very small needle, usually a 26 FG needle, so that
we minimize the discomfort to the patient. And we find that this anesthesia can last almost up to about 2.5 hours. You can always top it up if you would like to. And even post-operative pain relief is pretty good. There may be some complications with not eliciting a history of allergic reaction to the drug, or it may be the reason for an infection at the injection site if you do not take adequate aseptic precautions, but these are rare and avoidable complications. So in summary, this is a block that we find provides adequate anesthesia for performing various procedures on the finger. The volume of the drug required and the time for anesthesia to set in is pretty quick and is very adequate. It has the advantage of a single injection with rapid onset, and we avoid giving multiple injections, especially on the dorsal side or in the web space. And it does have a theoretical disadvantage of an infection or a flexor tendon sheath injury or to the tendon itself, but provided that you stay perpendicular, you do not, move the needle a lot, and you are using only one single pin prick or injection prick, these complications can be avoided and use this more effectively. So just a quick presentation on a daycare kind of a anesthesia technique that hopefully some of you might find useful. Thank you.
Yeah, Abhijit, I think you have highlighted a very, I think, a different technique. Also, you have solved or answered my question about the injury to the flexor tendon by acknowledging that it can happen and you have to take care. And what gauge of needle do you use?
A 26 French grade, sir. The tiniest one, the one that we use for insulin injections, or a grade larger than that, 26.
Which drug you are using and what is the dilution?
No dilution, sir. We just use plain 2% Xylocard. Xylocard does not have any additives to it. So the risk of causing any allergic reaction is minimal. And for a patient who has not received any local anesthetic prior to the procedure, we always give a test dose to confirm that they don't have an allergic reaction to the drug. And
ask a question.
Yes, sir.
So, Dr. Abhijit, you mentioned 3 ml of local anesthesia.
2 to 3 ml.
But is that sufficient to do a surgery for half an hour to 45 minutes?
2 hours.
Up to 2 hours. Oh.
Yeah. And like I said, if the patient has any skip areas or if the anesthesia is wearing off, you can very quickly top it up again without much. And with the ring tourniquet or the finger tourniquet in place, you don't have to release the tourniquet or take it off. You can just top it up. But we have used it umpteen number of times. This is our method of choice, and we have never had to, even for a 2-hour surgery, we didn't have to top it up. It works very well. Looks like
Can I ask one question?
Yes, sure.
So what is the maximum time you can operate in a digital tourniquet?
Oh, good question. So in the United States, there are these commercially available ring tourniquets that are available, and they are kind of pressure calibrated. I don't have the exact details, but I think it's pretty much the same as your pneumatic tourniquet for your arm. I would not suggest that you use it for any more than an hour and a half.
No, the technique what Samrat showed, in that case, what is the maximum time?
Not more than an hour and a half, 90 minutes max. That would be my, there's no data out there to say for how long, because the way we use it, the pressure is uncalibrated. We don't know how much pressure it is exerting. But I think common sense would tell you that you would use it for the short procedures, such as a nail bed repair, or maybe putting in a K-wire for a mallet finger, or maybe for a quick extensor tendon repair, or draining some kind of a paronychia, which usually lasts for about 15-20 minutes or so. And you can take off the tourniquet at that time. But you should not stretch the time limit, where you're risking the finger circulation.
I think Dr. Towry told that you can do surgeries which are requiring time less than 25 minutes or like this. There's the procedure which can be done within 25 minutes. Whether Dr. Towry is there?
Yes, sir.
How
yes,
much?
sir. So that is the literature support. That is what is about 20 minutes. I could not find literature support of more than that for duration for digital tourniquet. That's what the literature says.
Okay. We'll have a short video from Pankaj.
Yeah, just a small comment. We all have read extensively about tourniquet palsies, and we know that the damage that happens in tourniquet palsy is because of the mechanical pressure that the tourniquet exerts more than the ischemia that it creates. And that is the reason for digital tourniquet, which is known to exert pressure anywhere between 300 to 500 millimeters of mercury. It is recommended that we keep that duration to as low as possible, notwithstanding that the ischemia it causes may not have much problem, but the local pressure it exerts on the nerve and the vessel could cause damage. Therefore, it is recommended that it is not be used for longer than 20 minutes. I'm sure we will find literature support which will say that it should not be used for more than 5 minutes, and literature support which will say it could be used for more than 1.5 hours also. But I think the logic says that it should be used for not longer than 15 to 20 minutes.
Yeah, I think point well taken. You have, I think, highlighted the fact that it can damage the neurovascular bundle, and we should always remember that in mind, or keep it in mind. Dr. Godke, a quick presentation, please.
Yeah. Thank you very much. So
I would like to do one comment. Along with the pressure, the breadth of the tourniquet is also important whenever we are using. So in finger tourniquet, the breadth is very, very small. So pressure generation at a particular neurovascular structure is much higher. So we cannot use it as more than 20 minutes as mentioned by Dr. Towry.
Yeah. Your point also very well taken, sir.
Thank you.
Yeah.
So this is we are presenting injections. So this is very commonly done office procedure in orthopedics, and this is injection for tennis elbow.
He is 31 years old male. He is complaining of pain in right elbow, which is not relieved by medication. So first of all, we always check on the normal side, which is left. So if we do this, there is no pain. But over here, at the lateral, see, he is having pain, right? The second test is Cosen's test. So in that, we ask him to do this, both hands. So first, you do dorsiflexion against resistance. Work kara, work, work kara, see, kute dukte, he is pointing to it, work, kute dukte. So these two things. There is one exercise for tennis elbow. I have found many of my patients with tennis elbow getting relief with this exercise. So I'll just show you. The affected hand will go down like this. The other hand will hold it like this. घट्ट पकडायचं, वर खाली करायचं, वर खाली. This is one exercise. Other conservative treatment, what we advise in tennis elbow is we ask for some Mulligan exercises, physiotherapy, and tennis elbow splint. So these all things are done with him, so he is not relieved. And now we are going for local steroid injection at the lateral epicondyle. To give local steroids at his lateral epicondyle. So what all things we need? We need injection Kinacort, that is 40 milligram. Then injection lock. We have 26 number needle and 24 number needle. 2 cc syringe 2. So this is all what we require. So now we will do is pain drip, and before giving any local injection, we should give xylopen sensitivity test. That is very, very important. And we are giving the local steroid now. As I told you, we should do xylopen sensitivity test, make a round and put the time at what time we have given. And after 10 minutes, we have paint and draped his hand, and now we are going ahead with the injection. So now this is the point of maximum tenderness. So he is having pain over there. So we will just give the injection over there. So the technique what I was speaking about is that this is local xylocaine. So we always give local xylocaine before we we give any injection. And so after paint and drape, we will find the maximum point of tenderness. Elbow is in slight flexion so that the muscle is relaxed. And first I will give local over there. So thoda dukhe. Okay. We are only going subacute and a little bit deep. So I will give 5 cc over there. 0.5. I'll just wait for 4 to 5 minutes so that the local will act over. So now the local is acting over there. So now I have taken this syringe in which there is Kinacort triamcinolone acetate 40 milligram with 0.5 cc of lignocaine, and now I will go at the same point and I will be injecting it over there. I'll go deep, right? And I will just inject this. Right? And now, instead of removing the needle as it is, I will change this syringe. I will put the syringe which has xylocaine, and I'll just give some part of it and remove it. So with this, what will happen? Yes, so I have removed it. With this, what will happen is the steroid will not spill all over, and he will not have the problem of white skin patches what usually come. And normally what we do is we do sealing with benzoyl seal. And once that is done, this is the sealing. This is the sealing with benzoyl seal, and then we just do some movement so that the injection goes all around the lateral epicondyle. And we ask them that this seal will fall off its own. Those are. Thank you.
So the important point what I wanted to share over here is after giving these local injections, they usually complain of these white patches which comes around. Like if you give it in the tennis elbow and this thing, or your decurvence, your carpal tunnel. So that usually happens when the needle with which we have given the local steroid, if we pull it out without giving a local, so the steroid will not spill all around, and they will not have this typical complaint of white patches which they usually come with.
I think the last point which you made is, I think, interesting. I have never had, I don't give too many injections, but I've not had this problem. I don't use Kenacort, I don't use Tricort, Vicort, anything. I don't use anything except Depomedrol if it is available. Currently, it is not available, unfortunately. But I have not had this problem of white staining. But that's a real, genuine problem, and we must warn the patients that the area around the injection may look white. But I think it's a good idea to flush that needle with a local anesthetic. Definitely, I've not used it. I've not seen it. It's a good idea, good learning for me.
So
Pankaj?
once we have started doing this, we are not encountering any patient with white patches.
Okay. Yeah, Vijay?
Can I just make a point? So the white patch or the white discoloration that we see is usually because of subcutaneous lipodystrophy or absorption of the fat. So one of the most important caveat to avoiding this problem is to not inject in the subcutaneous area, stay away from that area. And then of course, what Dr. Ghorke sir has suggested can also be an added trick to avoiding this problem and counseling the patient as well. Thank you.
May I ask, may I ask one question to Dr. Hemant Patankar? Presently,
Yes.
Depomedrol is not available in market. Then what drug you are using? At least in Sangli, there is shortage of Depomedrol.
Sorry, sir, I didn't get you at all.
Depomedrol is presently not available in market. So which drug you advise or you prefer?
No, I don't. Somehow I'm not very happy with Kenacort and Tricort and all these drugs. In fact, on the drug prescription or on the drug bottle or on the pack, it is written that it is not meant for these injections. That is what is my take on this. Kenacort is an injection which is meant for it's an intra-regional this thing. It's made in oil. I think these drugs they are not worked in my hands.
And we are also using Depomedrol, but recently 4-5 days when I asked in the market in Sangli, Depomedrol is not available. Some another substitute for the Depomedrol has introduced.
Currently, it is not available. Yes.
Can I make a point, sir? This is a very important topic that we all should discuss, I believe. I had the privilege of being one of the co-faculty of the tennis elbow symposium in the IFSSH meeting in Berlin last year. And we had the who's who has been describing treatment protocols for tennis elbow. And the unanimous kind of conclusion was that nothing works best for lateral epicondylitis as does non-operative treatment in the form of activity modification, physiotherapy, splints. Injections also, we all know that there have been several studies that have compared placebo, steroids, autologous blood, PRP, and none of them have shown any conclusively compelling evidence to prove their superiority or efficacy over the other. So I don't think injections is the answer for lateral epicondylitis, as Patankar also, sir also had mentioned that it's very rare. And more often than not, you have to counsel the patient that he may not receive more than one injection, and that too with a lot of caution, a lot of counseling. We should embark on giving injections. This is just my 2 cents, but obviously, patient demands, practice, kind of directions influence the decision making. Thank you.
Another very important thing again is rest, which we cannot purchase, which
True,
is,
sir.
I think, the treatment of tennis elbow.
True, sir. True. I agree.
Yeah, Pankaj?
Yeah, I completely echo Abhijit's comments. I mean, I had the opportunity to discuss it with some of the who's who in hand surgery, and some of them said they themselves have treated their own tennis elbows absolutely in a conservative fashion, and their personal experience also has been it takes about 1 to 1.5 years for it to settle down. Whether you can afford to do a good activity modification during that period, decides whether you'll end up taking those many injections. Other than giving temporary injections, the tennis elbow temporary relief, the injections may not help much. In fact, it has been found that patients who get temporary relief, patients who opt for steroids for temporary relief actually end up having more severe recurrences of the disease as the disease progresses than those who opted not to have that injection and just decided to observe it over a period of time. They tend to have a much milder disease as the time progresses.
Yeah, we should highlight the fact that it is a self-limiting disease and nobody has ever died or become crippled because of tennis elbow. I think we should tell that to our patient. Yes, Dr. Jindal.
I think name was Mafuli. He was here in one of the IOA meetings, and he said anybody giving a steroid in the hospital is thrown out of the hospital. So, I mean, that's the rarity with which the injection is given. And if at all, because if the patient is going to come to me and 6 months down the line is not okay, he's going to go to Hemant. Another 3 months is not okay, he's going to go to Dr. Shinde. Another 3 months is going to go to Godke. So he'll keep traveling and going from one place to another because he's frustrated. He just 1 year of tolerating pain is just too much for him. And rest again, you can't tell him rest for 1 year. So there's a point he wants some benefit and some relief. So if at all at one point he's just getting too much frustrated, a single shot of water soluble injection. I'll give a single shot of water soluble injection. The problem is if you give it relief, he goes on to the previous level of his activity. The rest which was coming because of pain is gone. He's back to his original level of activity, which he should have curtailed. And because it goes back to the original level, the pain comes back. Now, if the pain comes back, don't go on for the second shot. So you have to have a bargain with him. Look, boss, I'm going to give you a single shot with great persuasion because of your frustration. I'm giving you a shot, but please do take rest. If you don't curtail your activity, the pain is going to come back and probably come back with a vengeance. If it does, then probably you might become a candidate for surgery or you might be worse. Your tissue is going to be more friable inside. Coming to trial of various things, yes, I have also read extensively about this thing. They compared PRP with everything. PRP equal to blood. The results were almost same. So take out blood. I remember seeing my grandfather when I was 80 years old, taking out blood IV and injecting it directly into the painful area. So yes, so that thing probably still works, but a single injection, if at all, I would give water soluble.
Yeah, Pankaj.
Yeah, on the point of tennis elbow again, rather than the steroid injections, it is said that tennis elbow happens and progresses because of overuse and disuse, both. So while we focus on rest as a part of initial treatment, what we have to really focus on is activity modification. I think prolonged rest itself will also aggravate tennis elbow. So we just need to be a bit aware of that.
Yeah, I'm sure. I think all your points are well taken, and I think we have to titrate the rest versus injection versus activity modification. You cannot go for rest for years together, as Pankaj has rightly said. I think every patient is a challenge as far as tennis elbow is concerned, and especially everybody wants to go back to his favorite gym, and that causes all these recurrences. We get all these youngsters and now a lot of these computer guys who come with tennis elbows, but if you ask them, they're surreptitiously doing a lot of over gymming, and their trainers who are 12th standard pass are educating them on the treatment of tennis elbow all the time. So that also is a problem.
To add,
yes, Dr. Godke.
Yeah, Hemant sir, one question for you. A busy orthopedic surgeon comes to you with tennis elbow. How do you manage that?
Pardon?
Not a busy orthopedic surgeon comes to you with tennis elbow, not getting relief.
Yeah, you tell him the truth. I think he knows it already.
He knows, but still
it is because of activity, and you ask him to take rest. I have had this myself. last full 1 year I am suffered from tennis elbow, and I have treated myself and nothing has happened. I have not taken a single medicine. I have just restricted my activity.
Also, Ashok, we should ask our orthopedic surgeon friend who has this tennis elbow to invest in good instruments and renew the instruments. I see a lot of people using poor instruments and thereby exerting themselves to a point where they might start getting tennis elbows.
Can I add two things on the conservative management?
Yeah, please.
Okay. So when we say activity modification, you ask them to use more of their flexors pronators rather than extensor supinators. So they should pick up things rather than lift up this way. That's one activity.
Right. That helps.
That's the second activity. Suppose there's a 1 liter saline bottle and they rest it on their they rest their forearm and they take a 1 liter bottle gradually down over half a minute. So they are not going to the theoretical part of this. So gradually go down, take out the bottle, then take the wrist again, hold the 1 liter bottle again, and over next 30 seconds again gradually go down. So do it about 10 times every 3 hours, so about 50-70 times a day, and that's a one activity that helps. I have seen quite a few of these patients who sincerely do this activity, this exercise.
Yeah, this sort of activity helps, but a busy orthopedic surgeon would not get so much time to do 70 times a day.
I'm willing to take up his locum post then.
Yeah, Pankaj.
Yeah, the technical name for what Dr. Jindal just demonstrated, immensely helpful. I use it all the time for a lot of my patients. It's called the eccentric loading exercises.
Yes.
So if anybody wants to search Google, that is the word that they can do.
Yeah, it helps. In fact, I also did
it. It is immensely
unknown.
helpful.
I should have asked Pankaj Jindal. I did it without. I found that this was the one which helped me, and it solved the problem. Abhijit,
yes, sir.
Can you ask? Can we ask Dr. Shinde for his concluding remarks?
Yes, I think we've had a fantastic webinar. Lots of technical points which are not usually written in the textbooks, but something that we pick up along the way from the acumen of seniors and experts that are present on today's webinar. And this is what we call as eminence-based and experience-based medicine. I really want to express my very sincere and heartfelt gratitude for all the time, the participation, the insights, and giving so freely of your experience, your insights, and your wisdom to all our participants as well as the audience. I would like to express my gratitude to Shinde sir, to the leadership of the MOA, for the wonderful opportunity. I think this has been an exciting and a very fruitful exercise for me to not only convene the session, but to learn from all of you. And also to everyone who has given so freely of their time and commitment on Sunday evenings to discuss, to participate. To all the audience who has taken the time to partake of the scientific proceedings, thank you very much. Shinde sir, would you please conclude the webinar? Thank you.
This is nice experience with you all. Highly informative discussion with the experts. Definitely, these wonderful ideas are helpful for the peripheral orthopedic surgeon of Maharashtra Orthopaedic Association. I am thankful to all for last 1 month. You have given a very good cooperation for us. Thank you, everyone. Thank you, Sham. And I hope if time permits, in future also we will have similar activities in future.
Thank you. One very quick word. Special thanks to Jindal sir especially, and also to very many others. For a lot of times, everyone has contributed at very short notices, and I apologize for the inconvenience that this may have caused. But thank you very much. And last but not the least, the man behind the curtains, Dr. Ashok Sham, who has always been so helpful. Last night, he prepared these flyers at 1 o'clock in the night, way past midnight, and he's always been there as a pillar of support and help at any time, at any odd hour that I would need him. Thank you very much, Sham sir. I really appreciate it. And we look forward to collaborating with you on very many educational webinars and events. Thank you so much.
During this hand webinar, I realized why the hairs of Pankaj Jindal are white. Thank you, Pankaj, for updating